dan IDI Surabaya. Dan pada hari ini kita akan diskusi mengenai preeklamsia dan telah hadir di tengah-tengah kita seluruh narasumber dan juga moderator. Jadi pada hari ini moderatornya oleh Dr. Purwata, kemudian dan juga dengan narasumbernya yang pertama ada Dr. Aldika Akbar, PhD, juga Dr. Ernawati, PhD, and also our special guest for today's Professor Steker. Good morning, Prof. And we're gonna talk about the conservative management of the preeclampsia, both contraindication and also indication. But before we start our conversation for number, I will give Dr. Brahmana to give a speech for today. Jadi mudah-mudahan hari ini kita bisa berdiskusi mengenai terapi konservatif pada preeclampsia. Please, Dr. Brahmana.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone.
Waalaikumsalam.
This is special session, special task, tanya apa saja, because now this morning we have our distinguished guest, Professor Gustav Dekker, among us, and then also the topic is so I think so important for us. And then thank you very much, Dr. Ernawati, Dr. Aldika Akbar, and then Dr. Kurota as a moderator, and then also Dr. Seto was organizing this webinar every week. Just to let Professor Dekker information about this webinar. This webinar is weekly webinar, never stop, very consistent, and then very on time, and then just 1 hour. And then now we got already 256 series right now this morning. And then hopefully that this webinar, especially today, is get high impact for us to deliver better practice to our patient. So thank you very much again for Professor Dekker, always supporting us, and also for all the speakers and all the moderators. Hopefully that we are still highly motivated to get new information, to get new insights from the expert around the world. Thank you very much. And also, Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you very much. Jadi Brahmana is our head department. Jadi pada kesempatan kali ini jangan lupa selalu kami persilakan pada seluruh peserta untuk bisa memanfaatkan fitur Q&A atau juga tanya jawab selama 1 jam ke depan, atau bisa raise hand supaya bisa diskusi langsung. Diskusinya nggak harus bahasa Inggris. Jadi biar nanti mengalir di bahasa Indonesia, mungkin nanti Prof. Das akan bisa menjelaskan Inggris. Jadi jangan lupa untuk mengakses laman pelataran saya selama 1 jam ke depan untuk bisa mendapatkan SKP dari Inggris. Untuk mempersingkat waktu, kami persilakan kepada Dr. Purwata selaku moderator pada kali ini. Monggo, Dr. Rita.
Terima kasih kepada Dr. Seto. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. So in our edition task in this week, we have a special guest speaker from the Australia, Prof. Gustav Dekker. So we talk about the preeclampsia, about how to management, and then the conservative management, and the indication, contraindication, and some issue about the preeclampsia. So in the first, we had some explanation maybe Prof. Dekker from you, so yeah, so you can share your screen.
Webinar, yeah, there. Good. Yeah, we're there. Yeah, good, fantastic.
Already audio.
Yeah, so selamat pagi and assalamualaikum. Of course, and that it's fantastic to be here back in Surabaya, which I consider my second home. And lots of good friends here. And I will talk a little bit about a bit of an introduction that helps us with the discussion later, that we wrongly have seen preeclampsia always as one disease entity. It's actually a syndrome. It's how you present. You present with signs of endothelial cell disease, But how do you get there is very different from one patient to the other. And if you look at, if you really try to make a simplification, there would be in the old times, it was primarily to do with placentation. And I'll come back to placentation, and that we now know is associated with what we call early onset preeclampsia. But society has changed everywhere, also in Indonesia, and we now see more late onset preeclampsia, where there's nothing wrong with the placentation. And I've given many lectures over the years on this topic. Is the placenta the culprit or the victim? Now, let's have a look. So my close friend and mentor, and this is Professor Chris Redman, and he died 2 years ago, really made the point that any type of preeclampsia that we see is caused by stress on the outer layer of the placenta, what we call the syncytial trophoblast, the outside cover. Go back in time a little bit. It actually, in hindsight, you always realize in hindsight that you can be very ignorant or stupid, if you would like, by not seeing this earlier. This is early data from my good friend Bahasi Bai. America, big population data in America, the birth rates in preeclampsia, gestational hypertension, and normotensive. You see, only in the very early pregnancy cases, the birth rates are lower. Yeah? When you get to the 34, 35, the significance disappears, and closer to term, birth rates are higher. There's no growth restriction close to term. So that's quite, we should have seen that earlier. And you can try to, if you think of the mothers of these babies, they both had severe preeclampsia for the mother, but their placentas, if you look at simple umbilical Doppler flow, was completely different. So this is very much like there's two camps. My old friend and mentor, Chris Redmond, he said the problem is placentation, and that is true for the type of preeclampsia that humanity has seen. Basically, you can say up to the late 20th century, 21st century. But as I mentioned, society has changed. So we have now gentlemen like Baski Tidakanathan in London, a very articulate professor there. He said it's nothing to do with placenta. It's a cardiac disease. Now, both of them, if you look at it, so these are all the data summarized that support the fact that there's a placentation problem, and it has primarily to do with immunology. Data on sexual relationship, change in partner, Treg cells, NK cells. This is all placentation. And this was certainly true for most of humanity. Nowadays, we get women at a much higher age with higher BMIs. They have continuous access to fast food, and they are just cardiometabolically unfit. They are chronically inflamed because of the obesity mostly, and that the inflammation also gives damage to the outer layer of the placenta. Well, this is a problem with the blood supply, which I'll show in a moment. This is just cardiometabolic inflammation. So just to see if this works here, yeah, it works. So this is the interval, just to refresh on the placenta, that's the interval space, fetal blood flow. This is spiral arteries. So the outer layer here is syncytial trophoblast, and that is, if you will spread it out, they calculated that mathematically, it's about 2 soccer fields. It's in syncytium, is technically one giant cell with multinuclei. It cannot repair itself. It ages, like the biologists say, senescence. And senescence is a inflammatory process. That's the core concept for all types of preeclampsia. In the early onset preeclampsia, there's also a problem with the invading cytotrophoblast. This is the, this is the same intervillous space, the villi. So here it would be syncytioblast. Here's the cytotrophoblast. And if I enlarge that, so this is the villi. Normal pregnancy, it goes into the spiral arteries, quite deep. And it dilates the spiral arteries. The distal part, the proximal part, I'll come back to that, stays the same in both entities. In early onset preeclampsia, but also early onset placental growth restriction, it's literally the mother's immune system that's saying, that's it, you cannot invade me anymore. And this is nicely, and this is an important slide from Charnock Jones and Chris Redman. The whole deficient spiral artery problem is a thing to do with early. Arbitrary, we think 34 weeks is a reasonable cutoff. And then rapidly you see that the whole story of the spiral arteries completely disappears. Close to term, there's nothing wrong with spiral arteries. Your own maternal susceptibility, your cardiometabolic fitness, inflammation takes the lead. You also see that with the birth weights. Close to term, the birth weights are fine. So yes, we talk. I'll come back to 34 weeks late. It's a arbitrary cutoff that we agreed on to distinguish between early onset versus late onset, and officially, and I'll come back to that, the diagnosis is preeclampsia that leads to the birth of the baby before 34 weeks. Well, I'll come back to that. But this important thing that, like with blood pressure and many things in medicine, to talk the same language, we agreed, okay, let's take 34 weeks, but it's a bit arbitrary. So just on that invasion a bit more. So this is that villus tree. So this is the intervillous space. Here you see the spiral artery that opens up because of the invasion. The proximal part stays narrow. Now you get a very nice, gentle, friendly laminar flow. In placentation problems, the proximal part stays narrow anyway. The total blood flow, and they have shown that stays about the same, but now you get high velocity pulsatile jet streams, and they are the damage to the early placenta. Not particularly, it's not hypoxia to begin with. So remember, placentation problems do not exist in term disease. Yeah. So to summarize, and we're getting to the finish, this is a beautiful slide from Annette staff in Norway, who worked with Chris Redmond for a long time. This type of preeclampsia, which we, for simple clinical practice, we say, oh, that's the early onset, but it's the placentation problems. The problem with the spiral arteries that are not transformed. The pure phenotype there is growth restriction. Depending on maternal susceptibilities, you may get the maternal syndrome. Much more common nowadays is the term disease, and look at this little clock here, because of unfavorable maternal health, diet, lifestyle, the placenta ages a bit faster, still gets stressed. You have syncytiotrophobal stress in both, mostly much more severe here than here, but in the end they cause the endothelial cell disease. Good to remember that this spiral artery story is also related to fetal death, abruption, placental preterm birth. It's not only preeclampsia. Also to remind you that early onset preeclampsia, and this is from the International Scope Consortium, where we were the Australian part, close to 6,000 healthy first pregnancies. Early onset preeclampsia is 0.5%. 28, the study took 4 years. We got 28 early onset preeclamptics. The rate of early onset preeclampsia in itself, and particularly Dr. Aldi with the INAPRESS group looked at the distribution early, late, which is a bit more difficult in Australia, in Indonesia, because the tertiary units get you get the cases referred in. But if you look at national data, typically like Australia, New Zealand, Ireland, of all preeclamptics, only 10% is typically early. If you go to Reunion Island, which I happen to know because a good friend works there, 31%. So it means that there are different pathways in different countries that lead to the disease, or the syndrome, I have to say. Now, just last slide on that 34 weeks. Is it preeclampsia before leading to birth, or the diagnosis? Now, let's go to a couple of points to finish my introduction. It has a degree of arbitrary cutoff. It corresponds reasonably with placentation problems. The official guideline is preeclampsia leading to birth before 34 weeks. Many national guidelines get a bit more relaxed about that, and they say, oh, it's the clinical diagnosis before 34 weeks. But you have to be realistic. If depending on your frequency of antenatal care visits and the tests that you use, if you use the modern biomarkers, you might see preeclampsia coming 3-4 weeks before the clinical disease. So I think if you use this arbitrary point, I would still be in favor for using the preeclampsia leading to preterm birth. For units that don't use expectant management, which we're going to discuss today, of course, diagnosis and birth are almost the same. But if you have a preeclamptic patient, it's good to go through the exercise that you think, is this actually a patient with a problem in placentation? And they typically have growth restriction, yeah? Or a particularly closer term, you know that they have no placentation problem. So when you want to analyze your own data or publish, I would say stick to the 34 weeks, just because that's the consensus in the world. Also split between preeclampsia with and without growth restriction. Remember, when you do growth restriction, there's a Delphi consensus to diagnose growth restriction. You can also just say, let's wait for the birth weight of the baby, and under the 5th or even 3rd centile would be seen as a very acceptable surrogate marker of growth restriction. And I think that's what I would like to say for introduction for the further discussion. Thank you.
Okay, thank you for your explanation, Professor Dekker. Maybe from the other speaker, from Dr. Erna or Dr. Aldi, is there any explanation about our topic today? Or we just go to the discussion maybe?
We don't have presentation, Dr. Rita. I think straightly to discussion is better.
Okay, so yeah, the preeclampsia is still like um, very dangerous disease maybe in Indonesia because the number is still high and the complications still make a maternal death, also the baby death, because most of them birth in premature. And yeah, we still seek the most properly management for this disease, for make improve for the mother health, also for the children. So in this question, Professor Dekker and the other speaker, we have a question from the floor that Dr. Haria asked, how about the preeclampsia in 30 weeks? How we do the conserve management? Is there any consideration? And then, or we must do the conservative management for 1 week? For 1 month. 1 month, I think, because we have In the severe feature, we do the conservative management until 34 weeks, like Professor Decker say in the presentation. And how about the giving of the magnesium sulfate? Is there enough for 20 hours or 12 hours or how? So yeah, maybe Professor Decker or Dr. Erna or Dr. Aldi can answer. Yeah.
I don't know if you're going to cover that in your presentations, but because of course we talk about conservative management. As a broad principle, in every patient with preeclampsia, you have to balance what are the maternal risks and what would be potential benefit for the fetus. So if there's of staying longer in utero. So clearly, you only do any conservative management with a fetus in a good condition, normal Doppler flow, and no extreme growth restriction, because that baby is already suffering. The aim would be depending on the stability of the mother, if you can control blood pressure with simple monotherapy, nifedipine, for instance, then you try to get you keep on monitoring up to about 37 weeks. That's for average preeclampsia. If the preeclampsia gets severe features, the whole dynamics change, of course, because there's acute risk for the mother. And then you start more counting in days and you prepare for birth with steroids, etc. If you need magnesium postpartum, particularly peripartum, the international data now suggests that you can stay with relatively short magnesium, basically no longer than 12 hours postpartum, unless they had eclampsia or still have neurological signs and symptoms in a nutshell. Yeah.
I think I can make some comment too. So the question from Dr. Haries, Prof. Quest, how long we can postpone the delivery for severe preeclampsia if we do conservative management. So from the explanation, I think we can postpone as long as we can with precaution that there is no danger in maternal and fetal side. So I think no limitation how long. And however, the target is 34 weeks, I guess. If 34 weeks, because of our NICU capacity is to take care of the baby is it's around 2 kilos, I think. So if we can reach 34, I think then we better deliver the baby. So I mean, maybe Dr. Arya asking too. However, if 34 weeks and everything is okay, can we extend the conservative management? Do you have any comment, Prof. Gas?
Yeah, I'm here, and it all depends. Like, what's the severity of the maternal manifestations? You have, of course, particularly now with the biomarkers that are extensively used. We often have quite early diagnosis now, 3-4 weeks before you would normally see it. These patients, you just carefully monitor, sit on. You might repeat the biomarkers again after about a week to see what the progression is. But I agree with you, when you get severe features, severe hypertension, any HELP features, levels of creatinine. Dr. Aldi did very important work on recently published. You can find it on any pulmonary involvement. It's like a sentinel marker, like this is going the wrong way. So I think we should be much more, also Australia, we should be much more disciplined in the initial assessment to do a simple oxygen saturation, all patients, and follow that. If you do conservative management, keep on repeating that. If you see any organ manifestations, clearly the mother's at risk. And then you're literally counting days And with any severe features, you would not. With severe features, I would not try to go beyond 34 weeks. Yeah.
Okay, so Doctor,
Yeah, so I think if we can postpone more than 34 weeks, I think is it the diagnostic of severe preeclampsia is true or not? I think yeah. Ideally, we can do the biomarker test here, but it's expensive,
Yeah.
so it's struggle here to do that. So I think if we can do so, we can predict maybe this patient is not severe preeclampsia, but other than might be chronic hypertension or preeclampsia. So why if severe preeclampsia, it should not be longer. We cannot longer do conservative management. Usually, in average, in our experience is about 2 weeks. Yeah, some cases it's 4 or 6 weeks. However, we do not know is it exactly severe preeclampsia or not. Yeah.
But that's, I think, if I'm allowed to add, and that's an important statement. Virtually all data, international, also the initial trial by Dr. Erna, now some years ago, typically in tertiary units, you gain something like 12 to 14 day maximum because the disease will progress. You only stabilize the mother. You don't cure preeclampsia. The only cure is delivery.
Okay, so the next issue, if we can do the conserve management of the patient in the preeclampsia, so we must do the patient in the hospitals, or the patient can we do conserve in the home, because in the hospital we get some issue like the cost, and then the family that must be with the patient in the hospital. So it's possible if the patient we do the conservative management with preeclampsia, we can do in the home. How about that, Professor Decker?
Is that a question for me? Yeah. So I think the location of the treatment, the severe features easy, they're admitted, but you have many of these cases that appear to have a more friendlier discourse of that the disease is not as aggressive. And then we use outpatient management. We have a special, in almost all hospitals in Australia, we have a women's daily assessment unit. Patient comes in for her daily assessment, where they look to see if there's any organ manifestations, what's the fetal condition. With a certain frequency, they repeated the laboratory test, and you can only do that with a compliant patient. If a patient is not, if she does not understand the disease severity and importance of coming back, we just keep them admitted. But
Yeah,
a reliable, well-educated patient who knows that coming back, who has no subjective signs and symptoms, we typically see them daily. Occasionally, you have patients that this is really, if you look at the symptom, it's primarily a bit of chronic hypertension with a bit of preeclampsia on top of it. We might see them every other day or twice a week. But the typical patients we are seen daily in the day assessment unit. And it actually reduces the stress for the patient. It's less costly. So I think that is the typical management for the milder cases.
okay. So what your opinion, Dr. Aldi? Maybe we can do this in Indonesia or no? Like we monitoring from the outpatient clinic with a patient with severe preeclampsia.
Okay, thank you, Dr. Rita. So I think I will just explain what we done in Binair Hospital. Because we have a patient with severe preeclampsia before 24 weeks. The condition is good, the fetal condition is good. We did the conservative management. But the problem is now with our universal health coverage, BPJS, they didn't give us enough money to do conservative management with the patient was fully hospitalized. So we make some modification if the based on ISIP guideline, if the diastolic blood pressure is below 90 or below 85, we send the patient to home, I mean outpatient clinic. So they meet us once a week in obstetric clinic, and we will terminate them at 37 week. So that is what we did in the Uner hospital broadcast. Maybe you have some comment about it.
Okay, thank you, Dr. Aldi. So maybe we can move in the next question. So this is from Dr. Irwin Lamtota. Dr. Irwin asks to us how we make a diagnosis about the refractory hypertension and what the indication for the termination of the pregnancy. And then if we do the conservative management in the patient with the preeclampsia, so what's the drug of choice of the for the hypertension? Maybe who can answer, Dr. Erna or Dr. Aldi? Dr. Erna, maybe, Doc. How we diagnose about the hypertension, the refractory hypertension. So maybe the mean of the Dr. Irwin question is if we have the patient with the hypertension and then no decreasing of the blood pressure. So when we can terminate this patient, what the indication, and then what the antihypertension drug that we can give for the patient.
Yeah. For our regulation, the initial treatment in during emergency situation, I think is first 2 days when patient admitted to hospital. During observation in emergency or high care unit, if we evaluate the patient and then we give a proper anti-hypertension management, and then during 2 days there is no improvement, I think it's not catch our target. I think we can diagnose that this patient is have a refractory anti-hypertension with note that we have enough dose for anti-hypertension. So we can do that if we have patient more than 160 and the diastole is 110, and then we have to decrease in I think in 60 minutes that we have to decrease the blood pressure. We can use, if we have orally, I think we can use nifedipine 10 milligrams, and then we evaluate after 30 minutes, and then if there is no decreasing, we can adjust, we can add more 10 milligram, and then 1 hour we evaluate. If there is no improvement, we have to change to IV anti-hypertension. We can see from Maggie publication, I think there is a like algorithm to how to decrease the hypertension. I think if in 2 days during 2 days we evaluate the hypertension itself, and then the laboratory, and then the baby. If we evaluate that there is no improvement from the condition, I think we have to decide that this patient cannot do we cannot do the conservative management in this patient, and we decided to deliver the baby. I think that's Dr. Ita. So if we already give the optimum therapy and antihypertensive therapy, then there is no decreasing. The target is decreasing of 20% of the MAP. So it's around less than 160 and 110 for the diastole. So we can say that this antihypertensive is work. It's no, we have to increase, or we have to change with other regimen. Maybe Prof. Gas or Dr. Aldi have addition for?
Yeah, I think I agree with Dr. Erna that if the moment you go from monotherapy to combined therapy, let's say you start with oral, or let's say oral nifedipine, for instance, and you need to, the fact that you do need to add, for instance, intravenous labetalol, which would be typically the second drug in Australia. If you already cannot control a blood pressure with two agents, it means that the disease is really winning. But that's more for research or tertiary centers. There's a potential use of intravenous nicardipine in tertiary centers with intensive care. But it means if you have to quickly, when you do your conservative management and you see that you're lose control of the blood pressure in itself, it indicates you that the disease, the syndrome, the sickness of the endothelium is progressing. Mostly you see other warning signs. Occasionally it's just the blood pressure, particularly for patients that have significant chronic hypertension with superimposed preeclampsia. They might have huge blood pressures while the baby's doing well, laboratory is fine. And these are the patients where you individually can, depending on the gestational age, you can see, are we going to add another agent, the third agent? These are very individual discussions that would be done typically if it's an early gestation, this can only happen in well-equipped tertiary centers.
So yeah, that's maybe can answer the question of Dr. Indi also. So if the patient had a chronic hypertension and then superimposed with preeclampsia, but there is no sign of the impending eclampsia, so the patient maybe can go through the pregnancy, still have a place for conservative treatment, but we can see weekly maybe in the outpatient clinic, or we can adding the antihypertension and third antihypertension like Prof. Decker say. So the next question, I think the two next question is the same about the HELP syndrome, and how and why we give the corticosteroid dose for the HELP syndrome, and if the patient is still premature, so we give doubling for the lung maturation, or how the dosing of the corticosteroid for the HELP syndrome. So maybe Dr. Aldi or Dr. Aldi, you can answer the question of from the
Yeah.
audience. Yeah.
Yeah, thank you. Question from Dr. Haria, my friend, my fellow. Yeah, so maybe later Dr. Erna will add something, because Dr. Erna research is about the HELP syndrome and conservative management. Yeah. So I think there is a different steroid that we use here, Dr. Haria, for the HELP syndrome. We use steroid that mainly work on the maternal side, but for the fetal lung maturation, we use some kind of steroid that work mostly on the fetal side, because like dexamethasone and betamethasone, they will cross the placental barrier. But for the HELP syndrome here, we use the usually prednisolone or methylprednisolone for the mother. This is very interesting question. Maybe I will also ask Professor and Dr. if the patient is having a HELP syndrome, but still preterm, we need to give a multiple steroid. Yeah, but if this case is my opinion is we prefer to give the dexamethasone for the lung maturation first. After deliver the baby, we can maybe switch the steroid to use MP or P for the HELP syndrome for the mother. And maybe the Rena will explain about his research about the effect of steroid in the HELP syndrome and conservative management. Yeah, Rena. Yes.
Yeah, I think for the steroid, it's still controversies in many journal. Is it work or not in HELP syndrome? It showed that corticosteroid just increasing it's help increasing the platelet itself, but not stop the disease. So from my dissertation with Prof. Gus as a supervisor, it showed that methylprednisolone compared to without methylprednisolone, the for the preeclampsia itself is not different, but the increasing of thrombocyte is faster in methylprednisolone group, and but with precaution, but we give steroid in case of preeclampsia. We have to aware if the patient have a infection. Maybe it's it can be the infection itself will be like relapse with the steroid. So we have to be careful in Indonesian setting to give steroid, that we have to see the patient condition. It's personally medicine, I think, is that we need to give steroid or not in HELLP syndrome. Even though in our guideline, in POCI guideline, we still state that steroid is allowed for HELLP syndrome with certain cases. Not all of HELLP syndrome need to give corticosteroid, but corticosteroid for lung maturation is a must if we have patient less than 34 weeks. I think Prof. Gas have addition for this question.
Yes, I think, of course, being closely connected to Dr. Anna's PhD, indeed. So for the severe preeclampsia in itself, steroids will not change the outcome for the mother and may only increase the risk of infections, etc. Question is for help. And after being involved with Dr. Anna's work, I also reflected on that, because we all have the clinical experience that there are a few HELLP syndrome cases where you think, I'm probably going to deliver very soon, and they give steroids for fetal indications, and the platelets suddenly go up. So, and I started to use that a little bit. Typically, if you think of HELLP syndrome, you're basically going towards delivering the baby. If that's very early and you give your, let's say, your fetal steroids, and you see the HELLP syndrome features really improving, particularly platelets, and if it's very early gestation, 26, 27 weeks, you might make individual decisions. Now, in this patient, I will continue steroids with the things like the intravenous, let's say, prednisolone, which will not cross the placental barrier, otherwise it's bad for the baby. But there's very individualized management in HELLP syndrome. So but they first need to show that they respond, that the platelets will improve for your routine fetal steroids that you're going to use anyway, because you're probably very close to giving birth. But the majority of patients with HELLP means that steroids for the baby, if it's very preterm, you have to think of magnesium, not only for mom, but for the baby's brain, the reduction in cerebral palsy, and then you work towards delivery of the baby. But there are clearly selected cases where you see an enormous improvement in platelet count after giving fetal steroids. And then you have to individualize in that patient.
Okay. I think it's clear about the steroid giving for the patient with a HELLP syndrome. So if the patient after 37 weeks, it's more easier for us. So after termination, so we can give some steroid for the HELLP syndrome for the mother. And the baby, it's still okay because it's already in term pregnancy. So it's more easier if the HELLP syndrome is happen in after 37 weeks. Like so, yeah.
But then you,
Yeah, okay. So we move to the next question.
I think the question from Dr. Indi not yet answered, Dr. Ita, about in chronic hypertension with superimposed 37 weeks, and the blood pressure is always more than 230 and 150.
Yeah.
Um, Yeah, I think if the blood pressure is in chronic hypertension superimposed, and the blood pressure is 230 and 150, it's very dangerous. It's crisis hypertension. If we show this patient with crisis hypertension, we have to decrease the blood pressure in 60 minutes. I think after that, if we cannot uh, uh, stabilize the blood pressure, I think it's indication to deliver because it's very dangerous. However, we have to to make sure the diagnosis itself is it only chronic hypertension or superimposed preeclampsia. If superimposed, it's a warning sign that this is a very danger condition to this
Okay.
patient.
Yeah.
I think it's we have to deliver if even they give optimum therapy and the blood pressure is still high, it's the sign that we cannot prolong the pregnancy, I think.
Yeah. So even though there is no sign of impending eclampsia, we if the blood pressure is not go down after we give some enough antihypertension, so there is no place for the conservative management.
Yeah, because I think the danger is not only impending eclampsia, but cardiovascular accident, other cardiovascular accident like CVA can happen also. Heart failure can happen in this patient. Yeah.
Yeah. Okay. 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 So we can move in the next one. Still have two questions. So the next question is about the patient with a history of preeclampsia, severe preeclampsia in the two previous pregnancy, and now she got pregnant in 10 weeks, and then we already give the micronutrient like vitamin D and then the calcium. So we can give more for this patient like a vitamin E and then the aspirin. How about your opinion, maybe Professor Decker?
So if I missed part of the question, this is a patient that had a history of
Yeah.
severe disease.
Yeah.
At the moment, the typical prophylactic therapy is low-dose aspirin, has to be started before 16 weeks, aspirin in the evening. And in Australia, we still use primarily the 100 milligrams, which is our standard tablet. Perhaps there's some, but still very controversial benefits to go to 150. If the I think just on if the patient has chronic hypertension, instantly managing her chronic hypertension will not change the preeclampsia rate. It will reduce the risk for bad blood pressure, but so you have to understand that treating chronic hypertension will be safe for the mother, but actually does not change this rate of superimposed preeclampsia. Talk about chronic hypertension. Actually, the data show that low-dose aspirin is less effective in chronic hypertension. It's a bit complex, but important. Still use it because you get less growth restriction and less placental preterm birth, but you don't affect the rate of the maternal syndrome. So we have low-dose aspirin. If you have, it is very much in the hands of fetal-maternal specialists. If you know the histology of the placenta of the previous pregnancy, and there was a lot of thrombosis, lots of big placental infarcts, there is a small indication area for adding low molecular weight heparin, and there's some very exciting research data from work by Dr. Aldi on the potential additional benefits of Perawatan, but we still desperately waiting data on long-term neonatal follow-up. There's no alarm sign. All the data that are available are reassuring, but the Perawatan babies, so to say, are now getting probably towards 5, 6, 7 years old, and we need to have a proper follow-up. But that's, I think, if you're a generalist ONG and you have that kind of case, it would be absolutely appropriate, of course, to call the colleagues in your tertiary center and say, we have this case, we have patients that had bad preeclampsia, next pregnancy, low-dose aspirin, bad preeclampsia again. And she wants to have another baby. Now, these are individual cases where you say, okay, is there a role for additional pravastatin after proper informed consent of the patient that we don't have long-term follow-up data? If you don't do this, I think I would, in Australia as well, I would, a generalist, ONG specialist, I would say, you have to talk this through with the fetal-maternal specialist.
Okay. Yeah. Yeah. So Dr. Aldi, how about your comment about maybe the pravastatin and then the vitamin E, like the audience asked?
Does not work.
Okay, vitamin E doesn't work. Any comment? Maybe from Dr. Aldi or Dr. Erna?
But prevention.
Yes, about prevention. Maybe
Yeah.
in the next question. So about
Yeah, yeah.
the prevention aspirin.
Oh yeah. I think aspirin is the main agent, Prof. Kas, for the prevention of preeclampsia right now, and also calcium for the
No.
country with low income like Indonesia. Calcium is also important, and also maybe vitamin D, although it's not officially in the guideline, but I think vitamin D is important because in Indonesia, Prof. Kas, more than 95% the pregnant woman have a deficiency of vitamin D. And I think from my research with Progress, pravastatin is showing a very promising result, as a supplementary agent for the prevention of preeclampsia. So from the biomarker and from the uh, clinical result, But same with aspirin, pravastatin is mainly work on the preterm preeclampsia, Progress, So, but the most the term preeclampsia or the late onset preeclampsia, which is the majority of preeclampsia cases, we still didn't found effective prevention progress for these kind of cases. Thank you.
Okay, Doc. So maybe you can give a explanation about the dose, like calcium. What does we must give to the patient, and then from when for the effective therapy, like
With aspirin?
aspirin, calcium, and then maybe the
So
vitamin D.
calcium, you can basically, if you know that you have a patient who is likely to be calcium deficient, and Indonesia is a low calcium intake country, you can basically, it should be used very broadly. When you meet a patient, you say, okay, unless she tells me, oh, I drink a liter of milk per day, start on
Yeah.
calcium supplementation. And listening to Dr. Aldi's words, and I've read some data that there's a lot of vitamin D deficiency. I would, in Indonesia, I would be very commonly use vitamin D as well, and that can be started when you see the patient. Aspirin, you typically start at about, I typically start at about 9 to 10 weeks. Definitely it needs to be before 16 weeks. Yeah? And in the evening, it's very interesting data. It works dramatically better in the evening because of pharmacokinetics than aspirin in the morning. Yeah.
Okay. So how about the dose? Maybe calcium, and then vitamin
Calcium
D.
1 to 1.5 gram.
Okay, and then the calcium, and then I'm sorry, and the vitamin D. What unit we must intake per day?
Yeah, either you measure it, but if you talk about costs, the vitamin D assay is very costly.
Yeah.
In our routine doses that we use in Adelaide, where we often measure it, if they're deficient, we give 5,000 international units.
5,000. Okay, yeah. So it's the same if we give with patient in history of preeclampsia and the normal pregnancy for the vitamin D for the preventing of the preeclampsia in this pregnancy, or the same dose like 5,000 IU.
Or if the patient has a healthy diet and you see in our setting and you see that this lady is having some skin exposure to the Australian sun, probably 1,000 units is already enough for general prophylaxis.
Yeah.
We are of course in a temperate climate, so in our winter season, I advise all patients to take 1,000 units because it's just less sun.
Okay. So any additional comment maybe from Dr. Erna?
I think it's enough for this, Dr. Rita.
Okay.
No more question.
Yeah, I think all the question already answered, and we just have 3 minutes before the webinar is closed. Maybe any statement, closing statement from Dr. Aldi or Dr. Erna or Professor Gas about our webinar today about preeclampsia. From Gas, maybe you have a closing statement before we close this webinar.
No, and I discussion often with Dr. Erna, Dr. Aldi. So different regions, even in Indonesia, there's huge differences. If you're urbanized area, rural, I would think that the risk factors and the pathways that leads to the preeclampsia might be quite different. So it's always good to, if you're a bigger hospital, secondary level with enough volume, look critically at your preeclampsia data. What is your typical most common type of preeclampsia? What would be you might be an area where there is nutritional deficiencies. There's areas where there is a shortage of things like selenium, which is an important antioxidant. So you have to look at your regional patterns, and in a huge country like Indonesia, I would expect that there are differences, particularly between heavily urbanized areas. And I think perhaps to add that the broader we, as we sit here, have grave concerns about the impact of poor nutrition fast food, highly processed food. So particularly if you're in, which is probably much higher in, let's say, downtown Surabaya than on some small regional parts of Indonesia where there is no fast food. So look at your data. Say, what's the nutritional background of my population? Could there be deficiencies? And I think you have to. It's good to get a feel for what are the big drivers of the preeclampsia in your region that you can modify, because you cannot modify maternal age, of course. We have shown the importance of controlling gestational weight gain in obese women. And there's good data there that you have to control. Let's say BMI 40, for instance, these women should lose weight during pregnancy, not gain weight. But it needs a motivated doctor, probably with a dietitian, to help the patient to have a optimal weight gain. That's a comment.
Okay, thank you so much, Professor Gas, for your explanation today. So, how about from Dr. Erna or Dr. Aldi, is there any closing statement?
I think it's enough, Dr. Rita already explained.
Already explained from ya, oke. Ya baik, mewakili dari departemen dan juga dari POGI Surabaya, kami mengucapkan terima kasih banyak pada kehadiran Prof. Gas pada acara Tanya Apa Saja pada edisi Veto Maternal kali ini. Terima kasih kepada Dr. Erna juga kepada Dr. Aldi untuk penjelasannya terkait dengan pembahasan kita preeklamsia, bagaimana merawat secara konservatif, kemudian indikasi, kontraindikasi, dan bagaimana penanganannya. Kami harap dengan acara TAS kali ini dapat memberikan ilmu yang baru, kemudian insight yang baru juga untuk memperbaiki dan memberikan peningkatan pelayanan kita kepada pasien-pasien preeklamsia yang tentunya masih sangat banyak di Indonesia. Sampai jumpa untuk TAS selanjutnya. Mewakili Dr. Seto dan Dr. Brahmana, kami mengucapkan terima kasih banyak atas kehadirannya pada TAS kali ini. Sampai jumpa pada acara-acara TAS selanjutnya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum.
For controlling the truth.